Welcome to my presentation on the cost of healthcare for the class Professional Nurse Role Manager, Nursing 479. In the year 2024, the United States spent more than $5 trillion on healthcare. 48% of that amount was covered by government agencies like Medicare and Medicaid. 92.1% of the population reported having some form of health coverage. Some information worth noting is that health spending occurred at a faster rate than economic spending. Hospital spending saw its highest rate of expense at 9.2%, which is the highest it's been since 1991. And the country spent just under $495 billion on prescription drugs. While there are many legislative acts that affect healthcare, the following three have the most impact on current healthcare and have been highly discussed in the media recently. The Patient Protection and Affordable Care Act was signed into law by President Obama in 2010, and it provided access to coverage regardless of pre-existing conditions. It also ensured access to care for more of the population, and it was significant for providing access for low-income families and people of color. The Inflation Reduction Act was signed into law in 2022. It was dedicated to providing lower prescription costs, reducing Medicare premiums, expanding health coverage, and it also eliminated a 5% coinsurance for catastrophic coverage. That act is set to expire in December 2025, and it was the main reason for the government shutdown recently, and it is what our legislative could not come to a conclusion on up until recently for expanding or extending those credits. Then we also have the Federal Reconciliation Bill, also known as the Big Beautiful Bill by President Trump. And the big thing about this bill is that it affects eligibility for Medicaid. And that eligibility is dependent upon whether or not a person is working or actively seeking to work, or if they are in school. The ramifications for this eligibility requirement is it could potentially increase our uninsured population by 5.3 million over the next 10 years. There are many factors that affect healthcare cost. The topics that will be presented in the next slides are those that increase cost by means of increased utilization of healthcare services. Those factors include unnecessary care, consumer attitudes, healthcare financing, pharmaceutical usage and the increased cost of drugs, and population demographics and disease patterns that go with that. Unnecessary care is considered to be care that does not contribute to the well-being of the patient. It contributes to 25% of wasteful healthcare spending. Schrank et al. Identified 6 areas that contribute to medical waste by means of unnecessary care. Failure of care delivery related to clinician inefficiency, variability in care, redundant testing, medical errors, or poor preventative care practices. Failure of care coordination, which is unnecessary ED visits and admissions, avoidable complications leading to unnecessary readmissions. Overtreatment, which is the overuse of low-value care related to over or underprescribing of medications. Overtesting and overdiagnosis, and overuse in end-of-life care, meaning aggressive treatment when hospice or palliative is appropriate. Administration inefficiency. This is multiple forms, paperwork leading to room for error, complex billing procedures, and hurdles to jump through to ensure patient care. Pricing failure, which is the variability and inflation in pricing of medication, testing, procedures, and medical equipment. And then fraud and abuse, which is, where others will absorb the cost whenever fraud is found. Adoption of appropriate interventions do have the ability to reduce waste and provide transparency on pricing. Interventions include QI initiative, and clinical pathways, which provide standardized care, telehealth visits and observation units to cut down on unnecessary ER visits and admissions, streamlining processes and eliminating redundancy to reduce cost, reducing drug prices, and applying value-based care models for incentivized care and cost awareness. Also, the removal for the need of prior authorizations to cut down on administrative waste and remove hurdles to access of care. It is important to note that the review by Shrink et al. Found that while value-based care models like hospital pay-for-performance programs and hospital readmissions reduction programs have improved population health, however, they have not been found to significantly affect wasteful spending. Consumer attitudes have the potential to greatly affect healthcare cost. Lack of timely care or limited access to appropriate care due to location and affordability can lead to progressive illness, uncontrolled acute episodes of disease processes, and exacerbations of chronic illness. Chen acknowledges that these issues can lead to anxiety and distrust in the patient population. In the current digital era, it is also important to shine light on the role that social media plays in shaping consumer attitudes. While social media can prove helpful in finding the provider that best fits a patient's interest, there is also the potential for damage. Misinformation spreads rapidly on social media, and with the rise of TikTok docs and those promoting naturopathic cures as better than pharmaceutical, there is a growing landscape for delays in receiving appropriate medical care. Healthcare is financed through insurance and out-of-pocket payers. Many times consumers are not aware of the costs prior to treatment, and while strides are being made to be more transparent when it comes to treatment, consumers are still blindsided by large medical bills that they're unable to pay. So this too can lead to delays in care, which, as previously discussed, contributes to the rise in healthcare cost. There are 4 different ways that healthcare is financed. One would be Medicaid, which is for those that are, Medicare, which is for those that are 65 years and older, and some disabled people. It is broken into 4 sections, A, B, C, and D, and those different levels provide different coverages and some optional coverages for care. Medicaid covers about 20% of the population. It covers the medically indigent, blind, disabled, and children with disabilities. Medicaid is funded by the state and by government. Then we have private insurance. Private insurance is offered through your employer, usually only for full-time employees. It can be purchased on an individual basis. However, if it is purchased in that way, it typically costs more for less coverage. Lastly, we have the out-of-pocket payer. This is for the uninsured and the underinsured. Each of these healthcare financing levels do come with deductibles, co-payments, and co-insurance. That is not always clear whenever you are initially signing up for these avenues of financing. Last year in 2024, drug makers spent $4.5 billion on TV ads to promote and push certain medications. RxBenefits.com reported that those who watched the Oscars were 477% more likely to see pharma ads than those watching regular TV programming. During a study on drug characteristics and direct-to-consumer advertising, DeStefano et al. Found that television advertising encourages consumers to request brand name medications more frequently than generic counterparts, and over those that the physician may be recommending for better treatment, and as well as increases demand and utilization of said advertised drugs. The study also showed that direct-to-consumer drugs exhibited a lower added benefit when compared to similar treatments. Another observation noted that direct-to-consumer ads may lead to distrust between the patient and provider in the event that the provider disagrees with the requested treatment option. For this example, we can consider the effect that direct-to-consumer advertising had on the medication Ozempic. Ozempic, which is a diabetes medication, was found in clinical trials to aid in weight loss. Direct-to-consumer advertising caused an increased demand for this medication, leading to market shortages. This caused some diabetic patients to need to switch to other drugs to control their disease process. This change not only impacted the cost of health for some consumers, but also had the potential to affect their health status as well. Population demographics and disease patterns go hand in hand. For one, as patients age, chronic illness tends to increase. This leads to more complexity in terms of illness, with the potential for more costly treatment. Currently, 8.3% of Louisiana's population remains uninsured. 63.2% of those report that insurance is unaffordable, while 27% report that they're not eligible to be covered. This puts those individuals more at risk to be hospitalized for avoidable illnesses. Uninsured individuals are also more likely to experience a decline in overall health while also receiving less diagnostic exams and therapeutic services. Access to care is a considerable issue when speaking in terms of health, wellness, and healthcare cost. For health wellness to be achieved, the patient must be able to attain access to care, meaning they must be able to overcome burdens such as insurance availability and affordability, transportation, and time constraints. Persons of color are most affected by the burdens that prevent access to care. These groups are more likely to experience low socioeconomic rankings, low quality or inadequately resourced education, and lower paying jobs. When access to health is attained, or access to health care is attained, they are also often subjected to stereotyping and racism that negatively affects their care and experience. Overall, persons of color have increased rates of chronic and debilitating illnesses, infectious disease, and higher risk of mortality. Evidence shows that decreased access to care directly relates to increased healthcare cost. Healthcare pricing is influenced by the government and reimbursement plans. There are 3 reimbursement models. The first is a cost-based system, which is where there is a cost plus markup of the service provided. The payer, who is the insurance or government, determines the allowable cost for the procedures, visits, or services. From there, a contractual allowance, also known as a discount, is applied to the bill, and the consumer or patient is responsible for the remainder. In a prospective payment system, the payer decides what services will be covered and how much of that service is going to be paid. The provider will absorb the loss if the service is underestimated, but they will also profit if the service is overestimated. Diagnosis-related groups are part of the prospective payment system. A diagnosis-related group, or a DRG, pays based on a predetermined estimation of care for a diagnosis. DRGs resulted in increased patient acuity and decreased length of stay in the hospital, possibly due to its relation to clinical pathways for streamlined services. For example, being admitted for heart failure. Finally, a pay-for-performance system is reimbursement based on performance and outcomes. So this is where our Press-Ganey comes into play. The Acquired Condition Reduction Program, Hospital Readmission Reduction Program. These do improve population health, but again, they have not been proven to affect the waste. There are some nursing interventions that nurses can implement to help improve cost savings, such as effective care coordination, efficiency, and continuity of care. Making sure that we have everything that we need to care for that patient right at that moment in time. Quality initiatives to improve frontline care, and prevent hospital-acquired infections such as CLABSI and CAUDI, advocating for appropriate clinical course for patients concerning procedures and medications. So this is antibiotic stewardship, pain medication, or discontinuation of higher levels of pain medications. Capturing charges in a timely manner and making sure that the billing department is not having to go back and put those charges in after the patient is discharged. Identifying barriers to discharge and anticipating the patient needs beginning on admission, not waiting until the day of discharge. And then discussing the cost of care with the patients. Nurses should also ensure that the patients have what they need when they need it to prevent readmission and to prevent health complications. In doing exercise 19.12 on page 427 of Leading and Managing in Nursing, it was discovered that increased levels of acuity require increased levels of nursing care. A unit with higher acuity patients will require more FTEs. The FTEs may not necessarily need to be filled with full-time staff since the acuity level may not remain consistent. Part-time work is a way to fulfill the level of nursing care needed while not going over the FTEs allowed. All businesses must keep accurate budgets in order to stay afloat and succeed. Healthcare is no different. The operating budget is the daily planning for the facility. It entails all expected revenues and expenses. The capital budget includes extraneous expenses not related to day-to-day functioning. This typically involves large expenses such as surgical robots or automatic doors. Once this purchase is made, a depreciated value of it is included in the following year's operating budget, presumably until it's paid off. The cash budget is free funds set aside for bills and cash disbursements. Variance is a measure of the projected budget minus the account performance. A positive variance reflects a savings or net positive of the budget. A negative variance reflects an overspent budget. Many things can affect the variance and budget, such as low census, unit repairs, and equipment purchases. When unexpected purchases arise, management may look for ways to save on other budget items such as staffing.